Yeah. Thank you, respected chairpersons. My topic has been a bit easy because my previous speakers has actually given a lot of introduction inputs to my topic. So, the noble markers and predictors of neuropathy in diabetes. So, we know there are several methods to classify peripheral neuropathy. We know there is mononeuropathies, multifocal neuropathies, and polyneuropathies which can happen in diabetes, and it can be due to axonal involvement, or it could be demyelinating, or it could be mixed one. And the most common is peripheral neuropathy, which can lead to pain, weakness, paresthesia, and lot of loss of tendon reflexes. We know that, and if you see, there might be axonal loss, there might be myelin loss, or there will be neuronal apoptosis from that, which can happen. And this is the pathophysiology. What happens? This glucose leads to development of actually there occurs glycation of the end products. There will be glycation, advanced glycated end products that actually deposited in the fibers, and that leads to development of the neuropathy. We know both type 1 and type 2 diabetes both can have neuropathy. You will see in type 2 diabetes, at onset, at present, up to 20 to 30% people have some sort of peripheral neuropathies, and 50 to 60% eventually develop diabetic neuropathy in due course of time. And these are the symptoms. These are unusual sensations: pain from light touch, muscle cramping, excessive sweating, heat intolerance, burning, numbness, twitching, getting full up quickly. There will be impotence, tingling, balance problems, reflex abnormalities, and also there is orthostatic hypotension. And these are the symptoms. We know that again in the heart there will be autonomic cardiac neuropathies that happen. From the blood vessels there will be abnormal vasoconstriction, vasodilation can happen, and also there will be a digestive and urinary tract problem can happen due to that. As I have discussed, the most majority is actually for peripheral neuropathies, muscle weakness, numbness, and tingling sensation, paresthesia. These are the common classical symptoms which happen in particularly specifically in a gloves and stockings manner. That means first there will be knobs of the foot will be involved gradually till when it reaches around just above knee. There will be fingers, all the hand neuropathies will happen. This is the gloves and stockings types of neuropathy. So you can see, of course, diabetes is one of the important cause, but in association of diabetes, there are few things one should keep in mind, that there is chronic alcoholism, nutritional deficiency, specifically vitamin B12 deficiency, inflammatory conditions like vasculitis, hypothyroidism, and certain autoimmune diseases usually come associated with diabetes, and they are also additional things which can produce neuropathy in them. And usually there are 5 steps. First step is whether it is slowly progressive or slowly progressive to long standing, or neuropathy with subacute onset or proximal involvement, or neuropathy with subacute or rapidly involvement, or sensory axonal neuropathy. As I have clearly shown, 5 different types of neuropathy are there. But what are the things we are going to do? What are the new things we are? One is, we know that nerve conduction study we classically do and this is mainly confirms clinical diagnosis of neuropathy. Also excludes neuropathy due to other reason like radiculopathy, distal myopathy. They can be excluded from that. Of course, nerve biopsy is another thing. You can do nerve biopsy. That will give a clear-cut idea about how much nerve is lost, whether this is axonal loss or the neuronal loss. And also on top of that, it can give about the etiological causes can be detected from particularly doing a nerve biopsy. Then there are certain peripheral nerve imaging. Like nowadays, peripheral nerve ultrasounds are available. They can do the ultrasound. There is a highly specific ultrasound. You can do ultrasound. You can detect specifically there is involvement of the nerve, and you can detect from that ultrasound. Or also MRI is another technique where nowadays there is dedicated MRI are there which can also detect peripheral nerves for particularly peripheral neuropathy. Then there is another is dollar neuropathic 4, that is DN4. It is one of the most widely used. It is a validated score for particularly symptoms and signs of neuropathic pain. Usually sensitivity to 80% and specificity 91%. Still, it is one of the commonly used in different guidelines is dollar neuropathic 4. Then this is Michigan neuropathic screening instrument. There is another MNSI is one very simple and non-invasive method to see what is happening to the neuropathies. It's specifically which a cutoff is 4, and if your cutoff 4 is taking, its specificity is to 92%. If you are taking a cutoff of 4. Then there is also another tools is the Toronto Clinical Neuropathy Score and the Modified Toronto Clinical Neuropathy Score. That is commonly used is now is Modified Toronto Clinical Score. It is a non-invasive method. It is also still validated for screening of diabetic neuropathy. This score, it is a good, reliable, and also very much reproducible score, and this score has been recently used in the evaluating of various drugs which is used specifically for neuropathy. If you are using, if the score is coming down, that also gives a clear cut idea that that drugs is effective specifically for this. Another is QST, that is quantitative sensory testing. QST is another useful tool. It is performed for particularly those who are having impaired sensory nerves, that is sensory nerve function is impaired or the conduction is defective. Both can be detected from the QST, one of the non-invasive method. It can also assess the features of neuropathic pain, and also it evaluate loss and gain in the sensory functions. Another is neuroaesthesiometer or bioaesthesiometer. We classically use this is 10 gram monofilaments we use, and also bioaesthesiometer. Classically, a lot of diabetic foot clinics have their bioaesthesiometers. It is another important thing which can detect and can also see the peripheral neuropathies in those groups. The another one is vibrative. Vibrative is also another tool. This is actually it is in the given a one specifically 128 hertz stimulus is given in the metatarsal head, and from that you can see how much patient is receiving and what is the score you can calculate from that. And this vibrative was compared with vibros as the bioaesthesiometer with a projective vestibular up to 90% with specificity of 84%. If vibrative plus 10 gram monofilament together if you are using, provide the sensitivity will further increase from the 50 to 62% if you are combined together. Then there is again in switch torch test, that is again another it is a method where 10 gram monofilament, if it is not available, you can use this. This is a very sensitive points. You place this point in the sensitive points, and that will give particularly your idea about the first, third, and fifth toe you are using this. That will give you idea how much sensory loss is there from particularly peripheral neuropathy. Neuropad is another thing, as it's a thing you are put your foot on the neuropad, and that will give a scan, and it will give how much sensory loss is there from each and every point. You can detect from that. It detects not only hot and cold and touch, everything can be detected from the neuropad. Pseudoscan is another scanner that is where it not only detects the neuropathy, on top of that, even if the function of the sweat glands, you can detect, because you know once someone develops autonomic dysfunction, along with neuropathy, there will be loss of sweating. So here the pseudoscan is another scan where it can detect how much loss in the particularly loss of the sweat glands function is lost, but you can detect from particularly from the pseudoscan, or also you can unmyelinated C fibers function can be detected from particularly cheap pseudoscan. There is another is Nerve Check Master. It is a portable device. It can detect neuropathy. It can detect heat and loss, heat and cold sensation. It can detect also autonomic dysfunctions all together, particularly if you are using this Nerve Check Master. Then nerve conduction studies, we know we have already. It can detect whether there is a peripheral neuropathy. It can exclude from the demyelinating neuropathy, from the compressive neuropathy to particularly peripheral neuropathy. There is another thing is corneal confocal microscopy. That is, you just see the cornea. From cornea, you can detect how much nerve or sensory fiber you are lost. And this is one of the important new technique. You can see from the cornea, you can detect how much particularly there is loss of sensory fibers from that. There is sponge skin biopsy. By taking skin biopsy, the advantage is that you are not only detecting neuropathy, you can also, a lot of etiologies can be discussed. It can be detected from particularly if you are taking sponge biopsy, and that will give a bright field immunohistochemistry and also quantification of the linear ILFLD. That will give an idea how much is lost and what is the etiology particularly of peripheral neuropathy. Then skin biopsy is also one of the gold standard. We know that. Regarding the management, already has been discussed. Gabapentin is one of the important thing, anticonvulsant. Another thing is pregabalin, topiramate, lacosamide, lamotrigine has been used. Then venlafaxine and duloxetine has been used. We know that. Along with amitriptyline, there is another is maprotriptyline is also used particularly for the management. Escitalopram, opioid specifically, tramadol has a lot of role particularly in the management. Of course, cannabinoids and topical ointment of capsaicin is also used for particularly these things. And also topical use of glyceryl trinitrate and isosorbide dinitrate are actually certain drugs which can be used topically, and that will also give some sort of benefits. Botulinum toxin type A is another important thing you can inject. That will give a significant improvement in peripheral neuropathy. Regarding the predictors, there are few predictors like inflammatory markers, brain-derived neurotrophic factors, vascular, endothelial growth factors, and a lot of receptors has been actually found. They directly can predict, if I detect a high level, they can directly predict neuropathies. These are the certain studies which are just will take another 30 seconds. That lot of studies which are, this is our study, own study, which has actually what we found, that the prevalence of diabetic neuropathy is very high, and it is directly related to HbA1c level, TSH level, hypertension, reduced BMI, and also early screening or early managing this HbA1c, BMI, TSH level, hypertension can cause significant reduction in TSH. This is our own study taking close to 400 patients, and these are the data from particularly specifically from our study. And why too soon predictors of time to diabetic neuropathy among new detected type 2 diabetic patients? A multicentric follow-up study from the Ethiopia that also shows that nearly screening of and early diagnosis complications is directly related to blood glucose level, directly related to blood pressure level, and also directly related to HbA1c level in this study. So, concluding that diverse pharmacological therapies are there for neuropathic pain, we know these are the lot of predictors and lot of methods and different devices has been actually now we have with us for particularly detecting and also predicting the peripheral neuropathies. So this management of course, ultimately the management of painful diabetic neuropathy is bit difficult. It is always not that much is patient always not get actually get 100% relief from neuropathic pain. Still, we have certain things that can give significant benefit to those people. Thank you.